Gaurang Shah sir, good evening. Venkat sir, good evening. Pankaj sir, good evening.
Good evening, sir. Good evening.
Good evening, Mahendra.
Sir, how are you after a long
Uh,
time?
yes. We were waiting to start, malignancy cases so that we can meet.
And it is on Happy Guru Purnima. Happy Guru
Oh,
Purnima to all of you, sir.
yes. Thank you. And to our teachers also.
Thank you, and sir. Yes, sir.
Yes, sir.
Yes. Our the biggest guru is now in front of us, Dr. Gite and Dr. Pankaj Maheshwari.
नहीं सर गीता साहब ही ठीक है
ये
No.
देखो सबने डिसाइड करके बकरा बनाने का प्लान किया।
नहीं.
Guru
ऐसा कोई आदमी नहीं है जो गुरु नहीं बन सकता, कोई।
Correct. I feel that whenever I am taking these classes, all the students who are answering, they are like my guru. We'll come to know and learn so many new things with them.
Exactly, sir. True, sir.
Okay. So, Brijesh, who is answering today?
Sir, Dr. Swastik.
Yes.
Dr.
Rohit. Anyone? Who else is answering?
Ekansh, Dr. Ekansh, Dr. Swastik, and Dr. Pratik, sir.
Three of them, no?
Yeah, three of them, sir. Dr. Pratik, Dr. Swastik, and Dr. Ekansh.
Okay. So you can load your presentation. Brijesh?
Yes, sir.
Okay, good. Fine.
Okay, sir. Just I want to brief all the students when you do not know when you present the case, is it a malignancy or the benign disease? So please be blind, don't be biased, and we are going to discuss how to approach a malignant case from the vague history and the specific history. So don't this is the localized prostatic cancer, but do not present this case as a localized prostatic cancer. Go by the history examination and do accordingly as per the history and the examination. Am I right, Gite sir and Gaurang Shah sir?
Yes, I agree with you.
Yes.
We are telling you which case presentation we are doing only because so that you can read and you can answer well. That doesn't mean that you should present it in such a way that you know the case. What Dr. Mahendra ji is saying is absolutely right. Okay. So
Sir, we will try to guide them because examiner knows that you know the case when you are presenting. So we will tell you what mistake you should not do during the case presentation and how to correct it. We will also guide you.
Okay.
So who is presenting?
yeah. So Brijesh will present, and there are three candidates who are answering today: Swastik, Pratik, and Ekansh. So three of them are answering. Okay. Brijesh, you can start.
A 70-year-old male present with the complaint of poor stream of urine, straining, and nocturia 2 to 3 times per night since 6 months.
Okay, don't jump. Don't jump. Now, with these three complaints and the duration, what thing comes in your mind? What things come in your mind?
Male patient presenting with these symptoms.
No, we can't.
This is most likely. Hello, sir.
Yeah.
Hello,
Yes.
sir. The most common thing that I will start with is a bladder outflow obstruction can be a benign or a malignant.
No. Your voice is not clear.
So
Your voice is
bladder obstruction secondary to benign prostatic enlargement is what I would think of first.
okay. So when these things are there, I would think this is the lower urinary tract symptom, and the cause may be from the bladder to urethra. Cause can be in the bladder to from the bladder to urethra,
Yes.
right? I will not
Yes.
go in the prostate. I will not go in the urethra. I will just go vague. I will make a broad picture, and with the examination and history, I will make a smaller picture later.
Okay.
Okay?
Okay.
Come on, go ahead. Go ahead.
Yeah, Swastik, what are the questions that you will ask?
So I would like to first elaborate the symptoms of lower intake symptoms, sir. I will ask about the frequency, urgency, nocturia, poor flow, intermittency, straining, and sense of incomplete voiding as per the IPSS score. I would also like to know the sexual history of the patient and the quality of life and bothersome score, sir, to start with. Then I would like to go towards the history of any catheterization, instrumentation, acute urinary retention in past, any history of breathlessness or pedal edema or facial puffiness, any history of weight loss, back pain in recent past, and any history of any comorbidities or family history of any significant family history, sir.
Okay. So can you just in a one line, can you elaborate whatever the history you're asking? What is significance of that?
Sir, the significance of asking for a history of any instrumentation or any catheterization in past or any history of acute urinary retention can be a history of detention is there for ruling out any prostate issue or any bladder related issue. Then in history of weight loss or back pain to rule out any metastatic symptoms, metastasis in history of facial puffiness or breathlessness or straining on walking or exertion, just to rule out chronic kidney disease, sir, by history, sir.
Okay, okay. So you know what are you asking and the causes of that, so that you can either rule out or you can include your positive history, right?
Yes.
Okay, okay. What you want to do after this?
So, Brijesh,
Now you
give the history.
So he was relatively asymptomatic before 6 months. Then he started developing poor flow of urine, straining, and nocturia. The complaints were gradually increased and now had worsening since last 2 months. He also had a mild history of weight loss. IPSS score is 18 by 35. Quality of life index is significantly affected, and he is not sexually active. And these all symptoms have significant impact and are very highly bothersome for the patient.
okay. So would you like to ask history of hematuria?
Yes, sir.
Yeah. Okay. So in hematuria, what points you will like to ask?
Sir, in hematuria, sir, number of episodes, sir, whether it was intermittent or continuous, whether it was complete, it was initial, complete, or terminal, whether it was accompanied with pain or whether it was accompanied with clots. If it was accompanied with clots, whether the clots are amorphous or serpentinous, sir.
Okay, fine. So I would suggest do more practice, and when you say it should be not in a very fast, it is a confident and little bit good manner when you speak, little bit slow.
Okay, sir.
What do you do next? Yeah.
Sir, family history, comorbidities, sir, in this patient, sir.
Okay. Okay.
Pratik, is there any importance of family history?
Yes, sir. Patient who in where there is a first degree relative having uh, prostate cancer, that can also be a cause of bladder outlet obstruction secondary to a malignant cause. History of malignancy, BRCA positive malignancy in families can be there, sir. That can also be asked, sir.
Anything else? Age is not important. Any family member who is having a younger age of presentation in CA prostate also, there is
Yes,
a
sir. Yes, sir.
risk of having prostatic cancer. Okay, fine. Next slide.
Vijay, go ahead.
Yeah. So he didn't have any history of burning micturition, no hematuria, no any recent previous instrumental catheterization, no abdominal pain, vomiting, fever, no backache, bony pain, puffiness. He was not sexually active. He had a history of left-sided PCNL 35 years ago, but documentations were not available. He is non-case of diabetes and hypertension, well controlled, and has arthritis, which is on treatment by a rheumatologist. He is non-vegetarian, appetite is normal, bladder activity is altered because of the symptoms, non-smoker, non-alcoholic.
Okay.
Akansh, what do you want to do? What is your clinical impression and now what you want to do?
So he's a 70-year-old male with comorbidities with bladder outlet obstruction secondary to benign or malignant prostatic enlargement, and with predominantly storage symptoms, with so much so that they are affecting his quality of life. It is quite bothersome to him, and it is severe LUTS, as we have seen, 18/35. So first, I would like to objectify it with a frequency volume chart or a maturation time chart, or preferably a bladder diary maintained for 3 days. And at the same time, start him on a alpha blocker, and at the same time, request the routine blood test, a complete blood count, RFT, urine routine microscopy.
Okay, so Dr. Ekansh, how do you know this is bladder outlet obstruction? This is not the bladder hypotonia, straining, decreased flow of urine. How, why did you mention about the bladder outlet obstruction based on these three symptoms?
Yes, sir. Yes, sir. I very much agree with you. It is quite a possibility, and that it could be bladder hypotonia. And but the first diagnosis, the first differential that I would keep in mind would be this. And then accordingly, as I will evaluate the patient, then I'll rule out one after the other.
So, so I will counter your argument with the having diabetes of 15 years causes neuropathy, right? Though he has noticed the symptoms for last 6 months. So I would like to suggest everyone, when you have a only history, please do not have only one diagnosis. Again, you have to make a broader picture, then again go to the little bit the narrow list. Okay. So now again we are asking you how to answer this question. What sir asked, what do you think? What in can be with this history? And so again, your answer should be based on the history. It appears to be lower urinary tract symptoms, storage or the voiding symptoms. Okay, the probable causes are can be, you can have at least 3 to 4 lists in your
Sir,
mind. Not
I
only
can I can have a list of diagnosis. Uh, um, for example, bladder outlet obstruction due to benign prostatic enlargement. Second, bladder outlet obstruction due to a malignant prostatic enlargement. Third, vesical calculus. Fourth, distal ureteric calculus. Fifth, as you said, detrusor atony, detrusor, and atonic detrusor, then neurogenic bladder as psychogenic component. Then we can have chronic pelvic pain syndromes. We can have bladder mass. We can have a foreign body. So this can be a comprehensive list of
If
these.
you give this much list, then the examiner will ask you what are the positive and supportive findings in this patient. Then you will be in trouble. You should understand what Dr. Pal is saying. It is not the list of 20 diagnoses. It is list of the most probable 3 to 4 diagnoses.
Okay, sir. Okay, sir. Sorry, sir.
Okay. So
Yes, sir.
yes, you said out of that bladder outlet obstruction, maybe you're right, stricture urethra, bladder hypotonia. That's all. 4-5 बना के छोड़ दीजिए आप, 3 to 4 बना के, ठीक है?
Sir,
फिर वो
sir,
पूछेगा,
I
हाँ
beg your
बोलो.
pardon. If I can answer your question of bladder hypertonia, I would also want to do an ultrasound, KUB, renal ultrasound with pre-void bladder volume and post-void
ये
bladder
बाद में
volume.
आएगा.
Examination.
The question was asked you
It's
based on
often considered as an today an ultrasound is often considered as an extension of clinical examination. So
भाई क्लिनिकल एग्जामिनेशन खत्म ही नहीं हुई है, रुक जाओ ना थोड़ा. अभी चिप कंप्लेन और हिस्ट्री ऑफ प्रेजेंट इलनेस में ही बात चल रही है. काहे भाग रहे हो? थोड़ा
जी हम उस पे आएंगे. देखो चीजों को अभी you take things like way. You are here to learn how to present the case in the viva. वाइवा में ये होता है कि आपको एग्जामिनर को प्लीज करना है, उन्हें ऑफेंड नहीं करना है, और अपने को विद लॉजिक अपने को प्रूव करना है कि वॉट एवर यू आर सेइंग इट हैज अ लॉजिक एंड अ रीजन. ओके, एंड गो स्टेप बाय स्टेप.
जो स्टेज में एग्जाम चल रही है ना, वो स्टेज के रिलेटेड ही बात करना है.
ओके सर.
ठीक है. ओके, तो we agree now कि based on the history, whatever the data, whatever the description we have, you have only 3 to 4 diagnoses. That is fine, agree. Okay, जो तुमने भी नाम गिना है. ओके, अब नेक्स्ट होगा, अभी अगला आप क्या करोगे? आपके पास हिस्ट्री पूरी आ गई, ठीक है? व्हाट यू विल डू नाउ?
Examination of the patient.
Examine the patient.
Very good. Now tell me what examination you will like to do in this patient. Anyone can answer. This is the learning class. Nobody is here to prove anything. This is a class for to learn how to
The
present case.
first the performance score of the patient. We can use ECOG performance score or Karnofsky performance score. What is the performance score of the patient? Then it will also entail how much.
Examiner will ask in OPD, all of the patient you do these scoring system. They are extensive one, na?
Just rough estimates, sir. How if patient is frail or if patient is
General condition. It is general condition.
general
Patient
condition.
चल के आया, उसका
General,
build कैसा है, उसमें आ जाएगा ना वो.
जी सर, जी सर, जी सर. General condition.
I know, I understand you have a great knowledge, but again, how to present your knowledge also an art, right, Gite sir? So वैसे करो present ना, चलो.
Yes, sir. So, general condition, then patient's vitals, and with special emphasis on per abdomen examination, digital rectal examination, and local examination, that is genitourinary examination. So, on per abdominal examination, we have to see any signs of any scars, sinuses, fistulae, any scars of previous surgery, abdomen is soft or not, abdomen is tender or not. is distended or not. Is there any fullness, suprapubic fullness? Then renal angle fullness, any renal angle tenderness. Then moving on, we have to in this male patient, we have to see the examine the penis, the glands, the external urethral meatus, the bilateral scrotum, and epididymis vas, and we have to do a DRE. In DRE, we have to first quickly do a focus neurological examination, checking the perianal sensations.
I want to interrupt you, Vikansh. I want to interrupt you. For Viva, you are going to get only 30 to 45 minutes. And
Yes.
if you use your half an hour only in examination, till half an hour, 20 minutes, then your Viva will only limited to this part only. Pen is normal. Pen is examination. You don't need to say external meatus, vas difference, epidermis. I will examine the genitals. That's all. Penis and the testis.
Yes, sir.
Am I right, Gaurang Shah, sir? This should be limited, right? These steps.
Yeah, means you each and every examination you say, but as you are saying very rightly, if you don't find any abnormality, just say that it's normal and go ahead. Otherwise, the discussion will go on. If you say that meatus is normal, what do you mean by normal meatus? What is the shape of meatus? What is the width of meatus? All these things they will ask. So, if it is abnormal, talk about that. Otherwise, say normal and go ahead.
Right?
Yes, sir. Yes, sir.
So use your knowledge wisely. कहाँ पे ज्यादा करना है, कहाँ पे कम करना है, it's all up to you. Okay? चलो
Yes, sir.
एग्जामिनेशन भी हो गया, लोकल हो गया, फिर लोकल में चीज रह गई, पेशेंट विद LUTS क्या रह गया, मेन एग्जामिनेशन.
DRE.
Yeah,
DRE.
we just show them.
Yeah.
So general examination was normal. For abdominal examination was also normal. Digital rectal examination showed a grade 3 enlargement, hard inconsistency with a smooth surface, and rectal mucosa was mobile. The rectum was empty.
Okay. So no nodule in the prostate, only hard surface, the hard prostate, right? And no
Yes.
nodularity seen.
Yeah.
Both looks sir, yes, sir.
Okay. Okay. Fine. So what do you think now? You have examination, you have history. Now what do you think?
So it's by DRE, it's a clinically suspicious, clinically palpably malignant prostate gland.
Probably. Okay. Which other condition can give a hard prostate other than malignancy?
Long-standing prostatic abscess, long-standing, which has become this thing.
Xanthogranulomatous prostatitis, sir.
Xanthogranulomatous. Xantho. Why not only granulomatous prostatitis, granulomatous? Xantho कहाँ पहुंच गया? Xantho will be the acute condition.
But the
Chronic prostatitis, granulomatous prostatitis, right? And malignancy.
yes.
Again, if you tell rare thing, you will have in trouble. फिर तुम फंस जाओगे. फिर your viva will go to the xanthogranulomatous prostatitis. वहां निकल जाएगा. Okay. Now what next after this?
Clinically, it appears to be a T2C disease. So I would like to confirm my diagnosis. I would like to have basic blood urine workup along with serum PSA and ultrasound of the KUV.
Right. And culture भी करना चाहिए ऐसी conditions में, because if it's when you have a clinical doubt of malignancy, patient will require a biopsy. So you have na
Yes, sir.
negative culture hand. Okay, and then I think in any LUTS culture is mandatory, I guess. Pankaj sir, is it there in today's guideline?
Yes, culture should be done, especially as you rightly said, we would be planning a biopsy in this patient.
Yeah. Okay. So उसके बाद क्या किया? स्वास्थ्य क्या करोगे इसके बाद? ठीक है, that is all normal. We assume that.
Sir, ultrasonography films and reports, sir. Films देखेंगे अपन.
Okay.
And sir, if ultrasonography
Just show all the investigations.
अभी I want to know what will be the sequence of investigation. चलो, आपने बोला CBC करोगे, सीरम PSA करोगे, कल्चर करोगे और एक
yes,
USG.
uroflowmetry. Sorry, we will do a uroflowmetry also, sir. And then if PSA is raised, sir, we'll also go for an multiparametric MRI of prostate and followed by biopsy, sir. If we suspect a malignancy of prostate. The sequence of investigation, sir.
The most common question the examiner will ask you, why not biopsy first, confirm the diagnosis, then do the MRI to save the patient money?
Sir,
because
biopsy first and then malignancy, sir, there will be artifacts. We will have to wait for around 4 to 6 weeks before the artifacts, because of hemorrhage or infection or prostatitis or edema resolves. So that we'll have to wait for the MRI. And MRI has a very good sensitivity and specificity for diagnosing prostatic lesions that are significant malignant lesions, sir. Pirates 4 and Pirates 5 lesions will be seen on MRIs. So we will do MRI first and then biopsies.
Okay, there is one more, you can say that guidelines also recommend MRI before the biopsy. And second thing, if MRI shows Pirate 2, we can avoid the
biopsy.
So you very well answered. Only thing is that you have to just make the answer well framed. Okay.
Yes, sir.
Good. Okay.
Sir, excuse me, sir.
So,
I want to ask you one question.
Sir.
Now he says that he wants to do first MRI. Suppose MRI shows that it is period 1 and period 2. Now in this case, will you go ahead with biopsy or you will not go?
No, sir, I will not go ahead with biopsy at all in this case before I have a urine routine microscopy and urine culture, or at least urine routine microscopy at hand.
What is the clinical finding?
Yeah. Gaurang Shah, sir, sorry.
What is the clinical finding? On PR patient, you are saying that it is a hard nodular prostate.
Yes.
So, irrespective of whatever the MRI may show, once clinically you are suspecting malignancy, you cannot stop at that level. If you are not suspecting, okay, suppose even the PSA is not raised, still you will do MRI and you will do biopsy. If you are finding a hard nodule.
Yes, sir. Correct. Sorry.
Understood. If you are not finding a hard nodule and if the PSA is raised, and if you do MRI and if it shows that it is non-malignant, you may watch for some time, you may repeat PSA, and then in case if it is increasing, you can go ahead for the biopsy.
So here, can we quote that the positive predictive value of MRI is around 85 to 90%. So for giving benefit of doubt and clinically palpable disease, we can still go ahead with biopsy.
No, Pratik.
Yeah, if clinically, if you are, yeah, Pankaj bhai, please.
My question, Pratik, is that if you have already decided based on DRE that you want to do biopsy, why do you want an MRI?
First of all, sir, MRI, I'm suspecting a malignancy, so MRI will be helping me for local staging. And post biopsy, sir, there will be artifacts, so I want to avoid that. So that's why I would like to get MRI first and then proceed with biopsy.
So let's make very clear about this patient up till now that clinically palpable disease, that MRI is not done to decide whether we want to do biopsy or not.
No.
MRI is done for local staging.
Yes, sir.
The decision of biopsy is already done.
Yes, sir.
Okay. and this will help you in planning the further treatment. And because post biopsy you will be forced to delay MRI, so you do MRI first.
Yes.
Mahendra, you agree, na?
Yes, sir. Yes, absolutely agree, sir.
So to put it in simple words, in this case, we have decided biopsy on the basis of DRE only, and then we are proceeding with MRI as we have to locally stage the disease and plan the management.
So let us have another scenario. This patient is having serum PSA of 29 and the same finding. Again, will you do a biopsy first or MRI later, or you will follow the same principle, MRI first and biopsy later?
So biopsy तो करना ही है, but if we want to do MRI, then MRI should be done before biopsy.
So again,
understand what sir is trying to ask. Now, if it is a nearly 30 PSA, are you expecting a localized disease?
No, sir.
So then why do you want MRI?
We'll do the biopsy first.
don't get confused. What guideline says? Guideline says in a biopsy naive patient and
MRI.
suspicion of localized disease, you should do what first?
MRI. Biopsy
Right?
naive and localized. MRI, sir.
Yes. So that is I am saying that DRE finding may is it going beyond the prostate?
No, sir.
You said
No, sir.
no. PSA 29 can have a many cause. Maybe the prostate is 60 gram. Okay, having a PSA 29, maybe having some mild infection, maybe some clinical infection, right? Or maybe
Yes.
PSA was done after the DRE. So again, DRE doesn't make any the great rise in serum PSA. But can be somebody has done good DRE with good pressure, that can be there, right? So again, I want to emphasize that knowledge को कहाँ पे किस तरीके से use करना है, this is all up to you. We are just guide you. कैसे and remember whatever the points we are telling you at this moment.
So can we
Okay.
also say that to find out the index lesion so that we can direct our biopsy better to that index
That
lesion?
that is also, yeah, you are right. But those things are only possible when the serum PSA is in the gray zone. Okay, anyway though, you can have it will help you to target biopsy. Okay, if the serum PSA is low, or maybe and the MRI is showing something parity 3 or 2, but the clinical doubt is there.
Okay, so one
Okay.
more question I want to ask, Swastik.
Yes, sir.
In this case, what type of MRI you will like to do? With contrast or without contrast?
Sir, creatinine, sir. Sorry. In
Creatinine
this
is
case, sir, we have a palpable nodule in this, sir. We can do without contrast also we can do, sir. In case there is suspicious lesion on T2 weighted and diffusion weighted image, we can do a contrast image, sir.
so here you are not interested because you are going ahead with a biopsy anyway. So you are not interested to find out whether there is any malignant lesion seen in MRI or not. Basically, you want to see whether it is the organ confined or it is not organ confined. Correct? And you are going ahead with. So, Mahendra, am I right? In this case, you may avoid contrast.
But again, sir, as Swastik said, if there is some doubtful lesion, so we can also add in the targeted biopsy. So I think if it is clinically not contraindicated, we should go ahead with the MRI contrast with the contrast.
Fine. No, because last time also when we were examiner, many examiner used to ask this question, and many of them they feel that why to do a contrast when you are already going for a biopsy. So that is why they should be open for that. They should
Yeah.
answer with a contrast. But in case if he asks, examiner says that why you want to do contrast, you can always say that yes, I'm going for a biopsy, so I may not use contrast.
Just can this? They can say that. They can say.
Yeah. Fine.
Okay.
Brijesh, go ahead.
I think pus cell is there and culture was negative or positive. Okay. So what can be the cause of that pus cells? 8 to 10 pus cells, no growth. Just I'm asking general urology question.
Granulomatous prostatitis.
Okay. What else? Can be there the sample was the initial
Sample
one,
error, sir.
not the midstream, the common one. Commonly it happens. Okay. Then what was done next? Okay. You should know how to read these images. Okay.
Yeah,
So
Pratik, will
Yes,
you like to read the ultrasonography?
yes, sir. Uh, Sir, ultrasound of kidney urinary bladder. In the initial images, there appears to be enlarged prostate with a significant IPP. The bladder wall appears to be slightly thickened.
how do you know it is thickened? There is no measurement of the bladder wall.
Irregular walls.
And bladder not fully distended also. Okay, go ahead.
Kidneys appear to be normal, sir.
Okay.
Hyperechoic lesion in the right kidney. There is a hyperechoic shadow with posterior shadow in the right kidney, sir. In the third film.
So where is that shadow?
Sir, third film, sir. First row, third film.
It is in the gallbladder, in the kidney, or in the bladder?
Kidney, sir. Kidney, sir.
Kidney. Okay, fine.
Right kidney, sir. Label किया है, sir.
Okay.
Okay. What it can be?
Sir, right renal calculus, sir.
Okay.
There is no evidence of hydronephrosis or there is corticomedullary differentiation of both the kidneys are normal.
Okay. Okay, report दिखा दो.
We can see some small diverticula in the bladder. In the second image.
Yes.
Let's see what the report says. They don't think it's a
So can you just summarize, Swastik? Whatever
Yes,
is your.
Sir, the prostate is enlarged with a pre-void of 153 cc and post-void is 86 cc, significant post-void residual urine, and a 30 millimeter size calculus is noted at the lower pole of right kidney, sir. There are 2 simple cysts in the mid pole of left kidney also, sir.
Okay.
Okay.
Prostate is 69
British?
grams, sir. Prostate is enlarged 69 grams.
So Swastik, just I would like to twist the scenario. Suppose that DRE is normal with serum PSA 9.4. What would you have done?
PSA 9.4 and so I
DRE
will
normal.
repeat the serum PSA.
It is 9.2.
Sir, on repeat 9.2, sir.
Yes, culture negative.
Sir, I would like to do a MPMRA for the prostate, sir.
Okay. And how to proceed if it is pyrade 3, 4, 5?
So 3, 4, 5, sir, I would like to go ahead with the rectal biopsy, sir, tusk guided biopsy of the prostate, 12 core biopsy. And if 1 or 2, sir, I will.
Again, there is another approach. You should see the patient apprehension. If patient is not too apprehensive, you can again repeat serum PSA after 3 months. Let us see how it is behaving. then you can again do the same thing. If it is so apprehensive, so whatever you said, it is okay, right? Okay,
Sir, here in the gray zone, can we mention about free by total PSA?
that you can do, but a different lab have a different this ratio. If it is less than 0.11, chances of malignancy is high. If it more than 0.11, chances are less. But again, what about the 0.11 ratio? Again, you are not sure, right? So now I think MPMRI is more specific and sensitive compared to the serum ratio. Okay.
Yes.
So just to stress this point, that if clinically benign and PSA is borderline elevated, even say there is no urgency for rushing with MRI, always suggest that I'll repeat a PSA after 4 to 6 weeks.
Yes.
And only based on that, then take a call.
What next? What we have done after the sonography?
We'd like to have your opinion.
Also, sir, CT to be done in this. Sir, there's a CT KUB to be done because of the stone in right kidney as on the USG, sir.
Okay, so you want to do CT KUB also, and you want to do.
So we can do MRI, CT KUB for stone, sir.
Okay. Can you go back? Can you go back to sonography report? Okay, this is 13 mm side calculus, lower pole of the kidney, but no hydronephrosis. Right. Okay.
Yes.
Okay, fine.
So Swastik, you see this patient has predominantly presented with low urinary tract symptoms.
Yes.
At this time, you have a disease of malignancy, suspected malignancy at hand. Don't divert towards CT-KUB at this time. This is a lower calyx stone, not an obstructing stone, no infection, or symptomatic patient.
Okay, sir.
So there is no hurry for CT at this time. At this time, you should concentrate only on the lower tract and the prostate.
Yes.
Okay. Uroflowmetry.
Now, Mahendra, one more question. Suppose
Yes,
in this case, the stone is little larger. And in that case, can we say that only the full MRI and we don't want to do two investigation, or we have to ask for the two different investigations?
Sir, we can always do MRI, but depending on the, suppose that if you plan for PCNL for localization of the site of puncture, CT is better or the this MRI is better. And again, always we can do a limited CT scan also. And one more thing about the timing of the this because it is a 9.2, so this cancer is not going to be a significant or maybe high grade or maybe 5.5 plus 5. So sequencing, maybe we can go ahead with the PCNL or this thing URS first, and then followed by under evaluation. By that phase, we can treat serum this thing prostate cancer later also, based on the patient symptoms.
Okay, fine. So I think okay.
Yes,
So yeah, that's what, because sometimes it becomes little tricky whether to talk about at Dr. Pankaj Maheshwari ji said, na, why to divert, for the incidental finding. But it depends on if it, as you said very rightly, we should keep it in mind. And if we are going ahead with the after diagnosis, first we diagnose the malignancy because that is a priority. But after that, when we decide for the management, we should be clear in our mind that how we are going to go.
So, sir, we have to balance which is the more emergency situation. Suppose that this patient has a bladder cancer and with the kidney stone, asymptomatic kidney stone. We should deal with the bladder, this thing, maybe the TURBT first, and maybe we can do later. But in this case, CA prostate, we know the serum PSA 9.2, it is not going to be a clinically so much significant cancer. And if the stone is symptomatic, let us treat stone first, and we can delay the biopsy by 2 weeks. It doesn't make any difference. And when she improve, we can progress. We can go ahead with the prostate diagnosis process.
So, Dr. Deepak Gupte, I hope you got your answer. You can unmute yourself, Gupte ji. Fine. Okay. Brijesh, show them what were done. Ekansh, will you try to? Okay. You are not expected to know about MRI in exam, but if you can, if you are knowing about MRI, you can just at a glance you
But,
can tell us what are the
but
positive findings.
sir, students should try to read about the how to identify extraprostatic extension, neurovascular bundles, bladder neck,
Okay.
and the ureters. Some anatomical landmarks which surgeons should know actually.
Sir, there is on this MRI done on so and so date of this 70-year-old gentleman. There is left posterior zone um, hypointensity in T2 weighted images, corroborating with ADC uh, ADC and DWI high values. This definite this extension is in the mid part of the left peripheral zone. I have to see the apex and the base also of the prostate, sir. But definitely in the left peripheral zone, I can see, sir. There's no involvement of the rectum. There's bilateral neurovascular bundles are free. Bilateral seminal vesicles are free.
And quite distended,
Yes,
right?
sir. Yes, sir.
Okay. Can you see the report? And what about where you describe this? You also mentioned about the pelvic node, and the bladder neck infiltration, any extraprostatic extension. Okay.
Yes,
Yeah.
yes, sir.
Okay. Can you see report? Okay. The pyrate 3, the right
Brijesh,
apex.
just read the comment.
There is an ill-defined T2 hypointense in the anterior peripheral zone of the right apex with restriction marked focal ADC hypointensity without early arterial enhancement, overall PRATS 4. Another T2 hypointense PRATS 2 and well circumscribed T2 hypointense nodule within the anterior transition zone at apex level of left side with the diffusion restriction on DWI with hypointensity on ADC maps with diffuse patchy heterogeneous enhancements in the transition zone. PRATS 3. So overall PRATS 4 in the presence of clinical significant cancer in high in anterior peripheral zone on the right at the apex level and low in bilateral posteromedial peripheral zones at the base level. And presence of clinically significant cancer equivocal within the anterior transition zones at the apex level.
Okay. So नीचे mention है on evaluation with the trust-guided biopsy suggested. So will you follow their suggestion or will you follow your knowledge?
Clinically, the disease is palpable, so anyhow, we had already had decision of proceeding ahead with the biopsy.
Okay. And what is the other supportive documentation you have?
So, there is raised PSA and bilateral disease on MRI also, sir.
Okay. Some more specific documentation is in front of you.
So PRATS 4 scores.
PRATS 4.
Yeah. Alright, 4. Examiner में they will ask how many chances of pyrate 3, pyrate 4 and pyrate 5 will have a positive biopsy rate. You should know that. Okay. Okay. So can we have a biopsy report? Can somebody read?
Sir, this is suggestive of a prostatic adenocarcinoma, prostatic acinar adenocarcinoma. Recent score 3+3 subgrade group 1 with 4 core positives out of 6 cores mentioned is, and no all the maximum core positivity is 15% in the 1A, sir.
Okay. So what is the problem of this biopsy?
So only 6 cores.
Yeah. The 6 core biopsy. Ideally should be
12 core biopsy. 12 core.
12 core biopsy. Okay. So it is not a adequately representative biopsy. Okay. Okay. So biopsy may, the other question can we ask the approach?
Yes, sir.
Transrectal and the transperineal. Okay. Now what current data says? Which is more
So
preferred approach?
transperineal biopsy. So transperineal biopsy is the more preferred one, and as it has a lower risk of infections as compared to transrectal biopsy. And in this case, sir,
go ahead.
In this case also, sir, on the MRI, sir, anterior zone and apex were involved. The regions were in the right apex and anterior zone, sir. So preferably, sir, transperineal biopsy will be better.
Okay. So you should know about the difference between the transperineal and the transrectal biopsy and what is the current evidence. Okay. As per the guidelines. Right? Okay. So what next? What done after this?
We have advised, sir, that he will require an operative intervention. So patient.
Do you did not want to have a complete biopsy like 12 core biopsy?
No, here they are saying that every zone they have taken 3, 3, 3, na?
No, sir. Both sides, sir, they have taken right lower prostate and left lower prostate, sir. 3 biopsies.
So on each side they have taken 9, if I'm not mistaken. See, multiple gray, then 3 gray, then multiple gray, then again 3 gray white linear tissue cores. So the 3 biopsy they have taken from all the 6 parts. So it is almost 18 biopsies they have taken.
Yes, you are right. A1B right posterior zone 3 gray and 1C right central zone multiple gray white linear. So it is A2 1PB and again 3 gray. You are right. 3 biopsy has been taken.
Oh.
So I think they have taken adequate biopsy.
Yeah. Right.
Yes, sir.
Okay. Fine. So chalo, we can assume that is a multiple codes are positive 3+3 and the highest is 15% of the biopsy. Okay. Now what next?
Sir, according to the NCCN risk stratification, this patient is having PSA less than 10. It's a grade group 1 disease. Then the clinically it is T2C, so this patient will be, and less than 50% of core positivity is there. So this patient will fall under intermediate favorable risk stratifications.
No, we do not know less than 50% because we have only report of 3 code, 3. There are at least 6 were there, or out of it, if 3, all 3 are positive. 1A, 1B, and 2A, all are positive. So it is not 50%. It is more than 50% if we see all the report. Even 2B also, 2C also positive.
4 out of 6 scores are positive, sir. PSA is 9.4 and T2C clinical, sir. EAU guidance, sir. Yeah. High risk T2, high risk disease. EAU guidance.
High risk.
T2C, sir. T2C 9.4 PSA and is a grade group 1.
So somewhere between favorable and
EAU.
unfavorable intermediate risk, maybe unfavorable intermediate
So
risk.
now Ekans come with the NCCN guidelines.
Yes, sir. Sir,
Yeah.
NCCN risk stratification is a very low risk, favorable intermediate risk, unfavorable intermediate risk, high risk, and very high risk. So very low risk is essentially Epstein criteria, where it's T1C, PSA less than 10, glycerin grade group 1, that is glycerin score 6, PSA density less than 0.15, less than 3 out of 6 scores positive, and less than 50% positivity. That is very low risk. Low risk is T1, C2, T2 to T2A, PSA less than 10, and GG 1, glycerin score 6. So then intermediate is T2B to T2C, PSA 10 to 20, and also this PSA and GG2 or 3, that is 3 plus 4 or is equal to 7, or 4 plus 3 is equal to 7. Now if it is 4 plus 3 equal to 7, it becomes unfavorable intermediate. If more than 50% core positivity, it becomes unfavorable intermediate. Or if any more than if 2 or more factors are positive, it becomes unfavorable intermediate. Then
So
high risk.
which category is this?
So this is unfavorable intermediate, sir.
All 3 plus 3. But nothing is 3 plus 4.
No, T2C is there, sir.
T2C.
T2C is both low positive, right?
Yes, sir. So on DRE, sir, bilateral lobes are positive. Sir.
Okay. Okay, fine. Intermediate risk. Now, what will you do?
Now
You have so again, I want to highlight over here, in malignancy and benign disease, the difference starts from here with the risk stratification, which usually doesn't happen in the benign diseases. And remember, this is the most important most important step when you managing malignant disease, because based on this stratification, the management is decided. Okay,
yes.
right? Okay. So now what next? It is an intermediate risk, maybe a favorable one.
Now according to the recommendations, we have to go with CCT, that is abdominal imaging, CCT abdo plus pelvis plus bone scan, plus if the risk of lymph node positivity is more than 10% according to nomogram, accordingly we have to go for suitable lymph node evaluation.
तो क्या क्या करोगे? तुमने सीटी स्कैन किया, बोन स्कैन किया, और नोट के लिए तुमने एमआरआई कर चुके हो. Am I right?
Yes, sir.
Okay. So you want to do a CT scan and separate bone scan. So any other thing you want to do, you can do. Having two investigation, any one investigation you want to do.
PSMA PET scan, sir. PSMA PET scan for metastatic workup.
Okay. So now Ekansh want to do CT scan and bone scan. Swastik want to do PSMA PET scan. Pratik, what do you want to do?
PSMA PET scan, sir.
So it has some logic, and just go by the majority. Two people want PSMA, we should go to PSMA, or there is some
The
scientific.
sensitivity of PSMA PET scan for picking up lymph node metastasis is higher, sir.
So why not doing CT scan and bone scan? If you do CT scan, bone scan will pick up the bony lesion, and CT scan will pick up the other thing.
Sir, even in bones, sir, the medulla involvement of the medullary part is before the cortical part, and bone scan picks up the cortical part, and PSMA PET can pick up all the metastatic disease that is there. So PSMA PET scan will pick up the bony metastasis earlier than the bone scan, as the bone scan also picks up metastasis at a very higher PSA levels.
again, let me correct your wordings. What you want to say, you did not choose the proper word. So your answer should be PSMA PET CECP is a single investigation
Yes, sir.
which can capture the metastatic site in the bone, in the nodes, and in the viscerals. Okay.
Yes.
About CT scan and bone scan, the sensitivity is hardly 50%, but with the PSMA, it is more than 90%.
Sir, your voice was breaking, sir. Can you please repeat?
Acha. Now it is clear.
Yes, sir.
Okay, I am saying the PSMA PET scan is the single investigation that can be done for the metastatic workup because it can catch bony metastatic, lymph node metastatic, and the visceral metastatic. Visceral. Okay, right? Which are the sensitivity of bone scan and DP bone scan is only 50 up to 50%, but the PSMA PET scan is up to more than 90%. Okay, correct?
Yes.
So do we have a PET scan after this? We have a biopsy now. Again, in the malignant disease, after the certification, you need to have a metastatic workup, which is not there with the benign disease. Okay, only NMIBC, where you routinely don't do metastatic workup. In other malignancy, you should always have metastatic workup. Okay, fine, sure.
Sir, in this case, sir, a low risk disease patient, sir, we will not do a metastatic work. PSMA PET scan, we will not do.
Low risk, na? Intermediate risk, na? Not low risk, intermediate risk.
No, sir, in case the disease is a low risk disease, we will not do.
Yeah, you can avoid. Again. But we do in our practice. You can always say in our institute practice, we do PET scan in every case. It's an institutional policy.
Okay, sir.
Moderate prostatomegalomegaly with the. Can somebody read?
Moderate prostatomegalomegaly with few focal areas.
Mahendra, only
Yes,
one
sir.
question that in
Yes, sir.
exam, once you are diagnosing CA prostate, is advisable to say PSMA PET scan in every case?
सर 3+3 गाइडलाइन रिकमेंड नहीं करता है बट एज इंस्टीट्यूशनल पॉलिसी कि हम यहाँ पे करते हैं तो वी कैन डू दैट because we have seen our practice some patient having 3+3 but node positive, so very rare. We have seen those. So maybe साल में एक दो से आ जाते हैं तो हम लोग तो टाटा में करते हैं हर पेशेंट्स में.
Okay, so they can say that sir, our practice, our
Right.
institute is following and they are doing PSMA PET scan. Fine. Okay. Next.
Second case, sir.
Yeah. Brijesh, just show them what else was done.
Sir, this patient
CT scan was done?
CT scan was done.
Done, na? Show them.
PET scan will go.
Does any one of you can comment? So,
Sir, this is a plain CT abdomen and pelvis. Liver
suppose,
spleen. Yes, sir.
1 minute, just first take 1 minute.
Yes, sir.
So, Mahendra, in this case, now if you already have done CT scan, and in that case, you don't want to do a PSMA PET scan, we can say that already CT scan is done. We will just do a bone scan.
Again, sir, the sensitivity of bone scan for NDP bone scan for the bony lesions is very less. And again, this CT scan will not tell us about the visceral metastasis, very small visceral metastasis or the lung nodule or the nodal, which is has an uptake on the PSMA PET scan. So ideally this patient should have PSMA PET scan, but अगर नहीं है और इसमें है, I think we should go ahead with the PSMA PET scan, though the chances are not very much, but we should go ahead with the PSMA PET scan.
Okay, fine.
Yeah.
Yeah, Swastik, you can read it.
Sir, CT abdomen. This is a plain CT abdomen and pelvis with the liver spleen appear normal. There is a hyperdense So there's a large lower portal calculus in the right kidney with no evidence of hydronephrosis on the right side. There are two simple cysts on the left kidney, sir. The cortical thickness appears to be normal, sir. Bladder appears to be well distended and the walls appear to be normal. Prostate appears enlarged in the films seen on the right side on second row, sir.
What about last row? Even you can see in the last row, sagittal section, you can see that.
Yes, sir.
Second film, last row, second and fourth picture, fourth film.
Yes.
Okay. What is the report? And again, in prostatic cancer, sir, also mentioned about the pelvic lymphadenopathy.
Okay, sir. Yes, sir.
Pelvic lymphadenopathy.
Yes, sir.
So there is a right renal calyceal radiodens calculi, left renal simple cyst, bilateral perinephric mild stranding, moderate prostatomegaly.
Okay. Okay. What's
Pratik,
done after this?
Swastik and Ekansh, I want to ask you now what you will do. Now I am giving you two options or three options. I will say that just active surveillance and patient doesn't have any other problem, so don't do anything. Second thing is you only tackle the prostate cancer, and the third is you tackle kidney stone and prostate cancer both. So Ekansh, what you will like to do?
So first, I want to counsel the patient about the report, all the report he has got, and break the bad news to him that he has got prostate cancer. Then I would.
I want to interrupt you. What did you say about the bad news? Why is it bad news? You are his physician. Why do you want to scare him? Why are you using bad news? This is the only disease status. What is he having? If you assume it is a bad news, that means you are already biased that cancer is a bad thing. But it is a very good result survival rate.
Correct, sir, correct. I meant to say to share the news with him first and counsel him.
No need to share the news. You have to just counsel the patient. How do you counsel it or person? I mean, there is no guideline how to counsel the patient. It's all individual basis. Only thing that you have to assure him. Okay. If you say initially, you know, I have a bad news for you. You have a cancer. He will collapse in your OPD. Maybe hypotension, something like that, and maybe with various symptoms.
Okay, sir, I would go ahead with the management of the uh,
No, you have to just you have to mention that I will explain the patient about the disease and the treatment options. जो है बताओ. What is your plan?
So you should say that with empathy and sympathy, I will discuss his problem, that is a stone, as well as the cancer of the prostate and the management of that. And what you are going to do now? Tell us.
I will explain both the treatment options. That is definitive radiotherapy and definitive surgery, radical prostatectomy, and then I will explain pros and cons of both.
And what about the stone? So you don't want to touch the stone?
Not at this stage, no, sir, because it is not causing the lower urinary tract symptoms, sir.
So if you give radiation therapy, then it will be easier job to do stone surgery.
Sorry, sir.
If you do radical prostatectomy or radiation therapy, if you give to this patient, will it be easy to do stone surgery?
No, sir. Definitely, it will be difficult later, but he's asymptomatic for that, sir.
Why difficult, Vikansh?
So Ekansh, my question is, suppose this patient doesn't have cancer of the prostate, and such a patient comes to you with the only incidental finding that he has got a stone of this size in the kidney, what you will tell him?
No, if he comes with just a report, then I will examine the patient and I will try to elicit tenderness. If no tenderness, and then I will order investigations. And if the investigations are normal, then I will periodically follow up the patient. Since there are no symptoms and no signs, and investigations are normal. If any of these are there, symptoms or signs or investigations are normal, then I will operate the stone.
Suppose after 6 months patient comes with septicemia.
Secondary to the stone, sir?
Of course, the stone might have slipped down into the pelvis, cause obstruction. Patient comes with hematuria, or he, he feels scared of the nothing is to be done. After 1 year, if he comes with a stagon calculus. Maheshwari ji, please explain.
Sorry, sir, मेरा दूसरा phone चल रहा था. Ekansh, what I would want to tell you is that understand where the examiner is trying to take you. It is not a question whether you are right or wrong. The examiner wants to discuss treatment of this stone, so don't be very firm that I will not treat this. Sir has told you that in case if patient does not have prostate cancer and this patient comes with a large lower calyx stone, why would you want to leave the stone behind if the patient is fit for treatment?
Okay.
Ekansh, you are understanding what sir is telling you?
Yes, sir. Yes, sir.
The only indication for not treating this stone will be if there is any other priority treatment that this patient needs, or if the patient is unfit for anesthesia. So now change the situation to a 90-year-old man with this stone. I would agree that okay, kuch nahi karo bhai, 90 years hai. But in a young patient who has not young means overall fit patient with a minimum life expectancy of more than 10 years with a large stone, there is no reason for completely leaving behind this stone. Yes, you may say that this treatment is not priority, or if there are any other priority management needed, those would take a precedence. But you will still need to treat this patient.
Yes.
You agree? You don't agree?
Yes, sir. I agree. Yes, sir.
So let us ask Mahendra ji, in this case, what, anyways, first thing, what you will like to do?
Sir, I would like to counsel the patient regarding the presence of both right renal stone and CA prostate. And I would like to also explain the patient about the risk stratification, or that the disease is intermediate risk, and about the management options that the patient that there are, like either a radical prostatectomy, minimally invasive or open, or radiotherapy. And I would also, from my side, I would like to perform. I would like to treat the stone and then go ahead with the management of CA prostate.
Sir, in this case, I would like to counsel the patient regarding the present disease status, and keeping in mind the significant bothersome LUTs the patient is having, along with the post-void residue. I would like to give the option of radical prostatectomy to this patient, and at the same time, I would like to counsel the patient that the stone is not a priority at present, and once the prostate part is taken care of, then at a later date we can plan for a considering 2.5 centimeter with 1400 HU, then mini PCNL for the right lower pole at a later date.
So Pratik, my question is why you want to wait for a stone? I just want to know when you are going to treat this patient, suppose if you do RIRS or if you do mini PCNL and within 2 or 3 days or 5 days or even 7 days, or for that matter, even 15 days, if you do a radical prostatectomy, uh, is it going to be harmful to the patient? What will
Uh,
be the more harmful? Suppose if you do radical prostatectomy, patient goes away. Now he says, no, I don't want to get treated for a stone because it is not causing any problem to me. And then when he comes, 33% chances it will grow, 33% chances that it may develop a complication. You want to leave it behind once you know it? How you
no,
are
sir.
going to benefit it? Is it going to help you in your, I just want to know, is it going to help you in your management of malignancy? Or if you treat it, are you going to, uh, like, give the lesser treatment to the patient as far as the malignancy is concerned?
So, uh, period of doing a stone first can be done, sir, provided that the patient is counseled well regarding the prostate malignancy status and the patient is willing. But I would like to offer him management for prostate first. But yes, stone management first with prostate malignancy management at a later date after a period of 3 to 4 weeks can be done, sir.
Pratik, as it is, you need to keep a gap of maybe 4 to 5 weeks between the biopsy and the definitive treatment,
Yes, sir.
especially if you are planning a radical prostate.
Yes, sir.
And in this intervening period would be the right time to treat the stone.
So,
Correct? Yes or no?
yes, sir.
Sir, also, sir, in case we do a radical prostatectomy prior and we do a stone later, either PCNL or an RIR, sir, we'll do a cystoscopy and all. Sir, will that increase any chances of recovery for incontinence later? Is there any effect of that on the recovery and of the continence, sir?
See, there are no papers which say that if you do any instrumentation after radical prostatectomy, then it increases the incontinence or anything like that. But theoretically, if you go to see, you are maybe, you are hampering the progress of the patient. There is no paper like that.
So you see, in this patient, I would say there is no single correct answer. You can defend this case either way. You could say that I would concentrate on malignancy first, as Pratik said, I would concentrate on malignancy first because that is the symptomatic thing that patient has had. Stone is incidental, peripheral, non-obstructing, no infection, no hydronephrosis that can be observed. One way of defending it. Or you can say, as it is radical prostatectomy, I'll need to wait for 4 to 6 weeks. In this period, I'll finish this off so that I don't want any risk of, say, obstructive uropathy, sepsis that happens post radical prostatectomy. So there is no single right answer in this patient. Either which way, you cannot be penalized.
Correct. And just see what the examiner wants. If he is more insisting on first treating the calculus disease, say that. If he is not keen on that, first talk about malignancy. Mahendra ji, how you will advise when such patient comes to you in your institute, Tata, what you tell them?
So the safest will be what? So, okay, am I audible?
Yes, sir.
Yes, you are.
So as
What you follow? We want to know what you people are following.
so, sir, is the same thing. We would tell the patient if it is asymptomatic, can we wait? Either the both things are right. While after the biopsy, waiting for the surgery date, he can go ahead with the stone surgery, so asymptomatic, or maybe he doesn't want after surgery. After 4 5 weeks, he can go ahead with the surgery. Both the way are right. Only how the patient prefers, because as you rightly said, if we wait for the stone for maybe patient lost to follow up and maybe he will come with a strong stag on calculi, very difficult to manage. At this stage we can manage easily. So both the logics are okay. If you ask me, I would have just the Pankaj sir said, till your biopsy has been done, with the stone, we have 4 weeks to 6 weeks to go ahead with that. You can go ahead with the stone removal and then we can operate later. As a swastik question about the incontinence, so incontinence depends on the surgical technique, how the bladder neck is spared, and that after some time it will not affect a single procedure will not affect the continence until we don't injure the external sphincters and we don't injure the bladder neck. Okay. Yeah.
So in this case, what was done, Swastik?
Brijesh.
So, sir, we have counseled the patient. Patient
Medical.
Yeah,
discussed.
Brijesh, what was done?
Yes, sir. We had counseled the patient and advised the patient about the consequences and about the disease, but he needs time, so he will reconsider and communicate with the family, and then we'll follow back.
Okay.
So in this case, any role of active surveillance?
So active surveillance is advised for either a very low risk, or some few cases of favorable intermediate risk group. As it is, our patient is in unfavorable, so active surveillance should not be offered to this patient.
Nowadays also, maybe he doesn't want surgery and radiation at the moment. He is scared of side effect of surgery and radiation.
Okay.
Then maybe he is not ready for surgery or radiation. He is afraid of surgical complications and the radiation complication. And he said, "Sir, kuch bhi karke, can we avoid surgery and the radiation?"
The focal therapies.
No, I want to tell you this thing. Ki few cases of unfavorable risk also can be there, provided patient is compliant
Compliant to
and
follow.
yes, and he regular follow up and he ready for the strategy of the this active surveillance. To that, what is the meaning of active surveillance? What is it?
So active surveillance is done with the curative intent and with the aim of deferring the treatment and complications of the treatment till the disease progresses, till the disease become the treatment of the disease becomes necessary. That is, we do not progress to the metastasis or local complication of the disease. So we do a periodic follow-up. The periodic follow-up is scheduled, and investigations done are DRE at DRE annually, PSA 6 monthly, MPMRI 18 to 24 at 18 to 24 months, and prostate biopsy, repeat biopsy at 2 to 5 years. And we have to intervene in case of if there is any upgradation of the upgradation of any progression of the disease, or the patient wants treatment, sir.
Okay. Mahendra, can we go for a second case? It is going to, it is for about your this question only. Mahendra.
So hangover, sir.
Okay. Brijesh, go ahead. Go for a second case.
Yes, sir.
Brijesh, go ahead. Finish the history.
So a 52-year-old male presented with the complaint of straining while micturition nocturia since 1.5 months.
Symptoms.
Yeah. So he was asymptomatic before 1.5 months when he developed symptoms like straining and nocturia. complaints inside is gradually progressing. He also started developing urgency. IPS score has been mentioned. He's sexually active, and these symptoms were quite bothersome, and quality of life has been significantly reduced because of these symptoms. No any history of hematuria, lithuria, dysuria. No any facial puffiness, exceptional breathlessness, lower limb edema. Blood and bowel were continent. No any complaint of incontinence. So he is just a diabetic. No any other surgical history. Nothing significant in family history. He is just a social drinker, non-smoker, non-tobacco chewer.
Yeah, so routinely we did the investigation. Just show them the investigations.
PRE. Right, low apical region.
So prostate was enlarged. There was a slightly hard nodule, like a hard consistency, right lobe in apical region. Rest everything was normal.
We will go ahead with urine routine microscopy, CBC, RFT, and PSA, ultrasonography, and neurochromatry. PSA 1.5.
Yeah, so what positive finding was that his PSA was 11.5.
Yes, sir.
Yes.
Normal.
Just see the report.
Prostate is 41 cc. Reward is 90 and postward is 22, sir. Debris in the urinary bladder and thickened urinary bladder wall with significant postward and enlarged prostate. Mild hydronephrosis and hydroureter to the UG on the left side. So there is a hydronephrosis and hydroureter on the left side. Overflow with a reduced peak.
Okay. So now what you want to do?
In view of the rest PSA and palpable disease, sir, we would like to get a MRI done, sir.
All right.
Brijesh, show them.
Lobulated lesion showing restricted diffusion on DW1 on bilateral posterior lateral aspects of peripheral zone of prostate gland and larger on the right side. The lesion is confined to capsule. No free fluid in the pelvis. No any lymphadenopathy.
That's 3.
That's 3 lesion BAPS.
Show them biopsy report. So Swastik, what do you want to do now?
Scan focus a typical small glandular proliferation is detected. ISC for basal cell markers is recommended for definitive diagnosis. Go ahead with ISC if possible, sir.
Yeah. ISC is done.
Rajesh,
हाँ सर
इतना ही है रिपोर्ट और कुछ है
यही है सर
ISC
ISC was done or not?
not available sir.
Not available. I think it was done and it was showing as adenocarcinoma, Gleason score 3+3.
Okay.
Sorry, sir.
Less than 5% of the core was affected.
That's in 5%.
Yes. So now, Pratik, what do you want to do?
Mahendra Pal sir was not there, sir, while the case was presented, sir. He has joined right now.
So I have some network issue, so just not the are you reconnected.
Yeah. So Mahendra, he was a 52 years old. He's a doctor himself. He came to us and he had basically lower intake symptoms. And on examination, there was a very small suspicious nodule which was palpable. And the PSA was high, 11.3 or something. Three times I had repeated. All the time it was just little rising only. And it had never come down to normal. Okay.
Mhm.
So we did MRI. MRI was saying period 3. We did a biopsy, and this is a biopsy report. And
Okay.
here IHC is not there, but we have done it. And it was less than 5% involvement. Gleason score 3+. It is adenocarcinoma.
Okay. And maybe single core involvement, right,
Yeah,
sir?
finger.
Okay, so he comes in the serum PSA maybe more than 10. So
10.
he comes in a maybe intermediate risk.
Intermediate
But
favor.
yeah, even the favorable, but the serum PSA, I think my personal view, serum PSA is not be so very strong predictor of deciding the risk stratification. So basically the T stage and the Gleason grade actually.
Here also the T stage will be
T2C.
T2C.
No, but
नहीं
which
नहीं सर सिंगल अपाइकल लोब ऑन राइट साइड है सर तो
only
T2
one, na?
B और A होगा ना
No, MRI is showing bilateral disease, right larger.
No,
So
it is only period 3. It is not showing bilateral disease.
Okay.
so it
And
may
the
be.
biopsy, see, the biopsy is not giving you.
So,
It is only one, and that also less than 5%. And that also Gleason score 3+3.
maybe it is only T1A, na? Single lobe and
Yeah.
T2S.
so it becomes
T2S.
maybe T2A, na? So either low risk or maybe favorable. Only by the serum PSA you can say is a favorable, but the other factors it is maybe the low grade.
Low risk.
So I think this is the ideal candidate for active surveillance. The only thing is that the important part in this practical aspect of this case is how to counsel, because this is the good news, not the bad news. I would like to say, right? So how will you counsel the patient in this scenario?
So account, you start. How you are going to counsel this patient?
Sir, this patient, I'll counsel by telling him that he needs to be on regular follow-up. He needs to be compliant. He, he and the current report is so and so.
Account, first of all, talk about the disease. First, you will explain to the patient, na,
Yes.
what is
Uh,
his problem and what is a favorable thing and why you are not going to operate and what is the other management you are offering this patient. Patient will ask you, doctor, I am afraid, please operate.
Yes, I'll tell him that after doing biopsy, we have come to the likely conclusion that he has obstruction because of BPH, which is prostatic enlargement due to benign cause, benign prostatic hyperplasia, and and for which we'll keep him on medicines. If he asks, I'll explain alpha blockers. Then after that, I'll tell him that compliance is a must. He has to regularly follow up the importance of and then give him a schedule of
No, you will tell him that with this, incidentally, we have also found out that is a small foci of malignancy in your prostate. Okay. And it is a very, very slow growing. We need not go for a surgery for that. And we can, correct, have an
this.
active surveillance in which way that, but the only thing is you'll have to come regularly. There are chances that it may not progress in a near future, but sooner or later you may require treatment for the same.
Correct. Correct, sir.
And then you say, okay, if you don't want to undergo surgery and you don't need it at present, I will make a schedule for you how to follow up so that we don't miss an opportunity of treating you. Correct? And then
Yes.
you say how you are going to do the follow up. So, Pratik, how you will do the follow up?
Sir, so 6 monthly PSA for malignancy, sir, and a repeat confirmatory biopsy report to be done at 6 months to 12 months, and MRI will be at 1 year, and then along with this, we'll calculate for PSA density also, PSA doubling time. If it is less than 3 years, then we need to evaluate further, sir.
Mahendra,
Yes,
in
sir.
this case, will you advise PSMA PET scan at this
No, no, no,
stage?
no, sir.
Because PSA is 11. That's what I'm asking.
No. Sir, PSA can be various cause. Na? Sometimes patient having 100 gram of prostate and maybe the 21, 25 this one serum PSA can correlate with the prostatic volume. So
Okay.
it is not like that. Again, I'm not so much fan of serum PSA while but it is there, so we have to calculate it. But many factors can affect its value. So more reliable on 11 serum PSA is okay. We can put an anti-surveillance, and as Pratik said, 6 monthly serum PSA, or maybe initially 3 monthly serum PSA, then we can increase an annually DRE. And in case of serum PSA rising and DRE abnormal finding, we can do multiparametric MRI and SOS biopsy can be planned. Can be done.
Okay.
Yeah.
Fine. Is it clear to all of you?
Yes, sir.
So if examiner asks about active surveillance, so the proper answer should be it is a treatment strategy for those patients where we can avoid over treatment for the given stage of disease to avoid the side effect of definitive treatment, either surgical or the radiation, so that he can have a normal lifestyle till the any intervention needed. That it is called active surveillance. That means actively monitored. That when we should intervene with the definitive therapy to avoid the side effect of this patient. If you do radical prostatectomy, if you do radiation therapy for this patient, maybe the patient having age of 65, 75. Do you think this disease may progress till his death? It will progress, but maybe not the clinically significant. So
Yes,
while doing radical prostatectomy, you will be over treating.
cancer specific mortality is similar on active surveillance and surgery both, sir.
Yeah. But in the PROTECT trial, in active surveillance, the chances of metastatic disease is more. So OS remains same. Okay. So metastatic also gives some bad quality of life. Okay. So can we then we have to actively monitor. So you should know the concept of active because they can also ask then what is watchful waiting? There also you are monitoring.
Yes.
What is the difference between watchful waiting and active surveillance?
The intent, sir, for watchful
1
waiting,
minute. 1
it
minute.
will be a palliative intent.
Can we have the third case, Mahendra? If you are through with this case, can we have the third case?
So कुछ different है कि it is like same only with watch
Yeah. Different. That's why.
watchful वाले ये लग रहे हैं.
It is for the watchful only.
Okay.
So 83-year-old male came with difficulty in passing urine since 2 months. He had
Just go ahead with the history first.
yeah. So he had lower urinary tract symptoms. PIS1 score was around 19/35. We evaluated the patient on general examination. There was tight meatus. He had mild phimosis with lower urinary symptoms clinically. DRE was grade 2 enlarged prostate, no any nodularity or anything. Serum PSA was also within the normal range. He had 54 gram of prostate with a significant post-void residue. Bilateral kidneys were normal. Uroflowmetry has also been mentioned. He had poor flow. PSA was 1.5. So it was typically of bladder outlet obstruction. Patient underwent circumcision with TURP. So this is the histopathology report.
Okay.
So histopathology report showed a small gland showed a loss of basal cell with absence of P63 and HMWK expression. And tumor just involved 1% of the tissue section.
Okay. No PNI. So what is your plan?
Yes, Pratik, what is your plan now?
Sir, so the patient will be patient is having a 3+3 score, and the tumor volume is only 1% of the resected specimen. So it's a T1A disease and low risk.
Wait a minute. It is diagnosed with the TRP specimen. This is not T1A. Diagnosed with the TRP, which is not T1C.
Less than 5% of the volume T1 is.
So T1C is needle biopsy, sir. T1A is less than 5% on resected specimen, and T1B is more than 5% on resected specimen, sir. And T1C is on needle biopsy.
Okay. I thought it is single lobe involved is T1A, bilobar T1B.
Sir,
That is T2.
T2A, BC.
Okay, okay. Okay.
So considering the age and the low risk status, so I would like to keep the patient on watchful waiting, sir.
Any scenario you would like to do active surveillance? Or maybe you have removed all the prostate cancerous tissue. What is the you can say gray zone in the cancer diagnosed with the TRP specimen?
Sir, so peripheral zone will not be present, sir. So we do not know exactly whether the complete lesion has been removed or it's just a focus what we are seeing on the biopsy reports.
So answer should be the most common site of prostate cancer peripheral zone.
Yes.
And in the TRP, we don't go up to the peripheral zone. Okay. So we do not know other part of the prostate is involved by the cancer or not.
Yes.
Whatever we have resected. Okay.
Yes.
But given a just have serum PSA of 1.5 with the size of 60 gram, having serum 1.5, having any significant prostatic cancer, conventional prostatic cancer is very low. Maybe the type of cancer like neuroendocrine cancer, where the serum PSA remains normal, cannot be ruled out. Okay, but 83, your answer is right. Having this scenario, 1.5, patient asymptomatic for the any metastatic or the local symptom, already we have done TRP, your watchful waiting is right. In which scenario you will advise active surveillance in this patient? Can I get the first slide, any comorbidities, and 83 healthy patient?
Brijesh, show the first slide.
So his life expectancy is more than 10 years.
How do you know? How do you know this in this patient? The life expectancy is more than 10 years.
Sir, based on we cannot know for sure, sir, but based on how long his father lived, then there are longevity indices like CCI, PCCI, prostate cancer specific
Charlson comorbidity.
Comorbidity. Charlson
So-
comorbidity index.
So basically, next day will survive, we can't predict. But by the family history, you said, suppose that in his family, all the male has lived more than 100 years, right? And he's apparently healthy. Okay, then this patient can be offered as a for any active surveillance or maybe different therapy based on the disease status, provided he is healthy and in the health index he is not in high risk.
Yes, sir.
Yes.
Okay, हाँ. भले ही वो नहीं लेता है, you can put on the watchful waiting, but in the practical and documentation you have to offer, right? But
Yes.
he is comorbid, family history 90 years, something like that, maybe 93 year, 94 year also, with no comorbidity, serum PSA 1.5 or single core positive, again he can be treated as a managed as a watchful waiting,
Watchful.
not doing anything. So that you can avoid side effect of any treatment, whether it is a EDT, surgical, radiation, whatever. Okay?
Yes, sir.
Yeah.
Sir, one
Anything
question.
else? हाँ,
Sir,
पूछो.
how do we shift patient? What are the practical factors we look into a patient while shifting the patient from active surveillance to watchful waiting, sir? Books mention age.
Disease progression. Disease progression and by the serum PSA, by the MRI finding or the biopsy finding. किसी का 3+3 था, उसके 3+ सिंगल कोर था, सिंगल कोर का 3 कोर हो गया, डबल कोर हो गया, राइट? सीरम पीएसए पहले 10, 8, 9 था, वो 12, 15 हो गया, and these multiple factors are there, then definitely disease progression. Then again, किसी का लो रिस्क था, मान लो सीरम पीएसए 6 था, ठीक है, 3+3 था, 1 कोर पॉजिटिव, आपने दोबारा कराया, बायोप्सी कराई, उसका सीरम पीएसए 9 हो गया, 3+3, 3 कोर पॉजिटिव, right? But again in the low risk disease. So again, if he compliant, if he understand that disease is, again you said the doubling time कितना होता है, अगर ये चीजें हर साल भर में हो रही हैं, having aggressive disease, 2 साल में हो रही है, not so aggressive disease, then again he can be continuing in the active surveillance part.
Sir, active surveillance to watchful waiting the shift, sir.
So suppose that किसी को रखा आपने active surveillance में, he develops some cardiac issue, which is he cannot reduce any stop the platelets, so surgical cost चला गया, but again RT can be given. But again, when the disease has a life expectancy become less than 10%, less than 10 years, then again you can switch over to the this watchful waiting. Anything else, Dr. Gaurang Shah, you want to add or?
No, I think so. That is why we took these three scenario, so that the students can understand when to answer about watchful waiting or active surveillance and management. So all the three scenarios we have. Luckily, we got all the three patients. We have taken
So
it.
at least
Sir,
we have.
In which cases we will offer focal therapy, sir? Do we offer a focal therapy in regular practice?
Now for exams, you have to answer the patient who doesn't want surgery or the radiation therapy, who are not unfit for surgery, right? And terminally ill patient at present, it is for those only.
Yes, sir.
Okay.
So we do not offer as a treatment for.
Papers are there, but definitive therapy के हिसाब से इसमें अभी कोई ऐसा रोल नहीं आया है.
Okay, sir.
So one of my patient, he is 72 years old, and he has got one core more than 5%, 3+3, and he went to institute and they said that you do HIFU. So in exam, you think that one can answer, or if they ask, we should talk about HIFU?
Sir, as a definitive therapy हम नहीं बोल सकते हैं, but अगर कोई पूछे what are the alternative methods of treatment, then we can say कि HIFU भी होता है, prosthetic artery embolization भी होता है करने को, तो वो भी कर सकते हैं. So that can be mentioned.
So in this HIFU, will you say that instead of active surveillance, you will offer him HIFU?
Again, sir, we are offering as a definitive therapy.
Definite management.
No. until patient is not fit for or willing for any further treatment, the hypo can be given. But as a primary treatment, Abhi, I think it is not a standard of care.
Okay,
Hmm.
fine.
Yeah.
Because one of the prime institute has offered HIFU to this
Sir,
patient.
sir, it is again institutional choice.
Okay, fine. But in exam, it is not advisable to talk about HIFU.
जी सर, जैसे कि प्रोस्टेटिक कैंसर में प्रोटॉन थेरेपी है, अभी
Hmm.
रेडिएशन अगर कोई एग्जाम रेडिएशन का, एंड इफ दे से फर्स्ट प्रोटॉन थेरेपी, they will be questioned that why you are not giving brachytherapy on the SBRT first, why proton therapy. But it is an option, can be given, but have a specific indications and the patient choice, cost wise, other things. Yes, sir. Okay.
Oh,
Any other questions anybody wants to ask?
okay,
Okay,
fine.
then.
Right.
ठीक.
So
Sir,
next time we
next-
are going to have a locally advanced. Okay. So Mahendra bhai, आप और अभी गणेश को भी जरा बोलो कि be ready for the next time.
Maybe sir is leaving somewhere tomorrow, so maybe he's not able to do that. But I think we covered localized prostatic cancer. Only thing is that locally advanced, we will talk tomorrow about the adjuvant radiation, everything we will talk on next class.
Okay, fine. Okay.
Okay.
Thanks.
Good.
Good
Thank you.
night to
Yes,
everyone.
sir. Good night.
Thank you, sir.
Yes.